Well, hi there everybody. Welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Anne-Marie and I'm one of the coordinators for Ovarian Cancer Australia's support programs. Before we begin today, I would like to acknowledge the traditional owners of the land. I pay my respects to their elders past, present and any that may be amongst us today. I would also like to acknowledge and thank the Brokaw Foundation for providing us with the funding opportunities to deliver this project. Today's webinar is on genetics and family history. You can ask questions of the presenters by typing into the chat box on the left, located at the bottom left-hand side of your screen.
Don't mind me.
Questions will be answered at the end of each speaker's presentation. Please keep in mind that our presenters cannot address individual medical cases. So if you've got any particular questions, please call the Information and Support line of Ovarian Cancer Australia, which will be on the slide at the end of the webinar. Today we're really pleased to welcome our presenters, Associate Professor Alison Trainer and Kristen Young, who's a consumer living with ovarian cancer. Associate Professor Alison Trainer is a geneticist with a specialist interest in familial cancer. She works at the Familial Cancer Centre of Peter MacCallum and the Royal Melbourne Hospitals. Alison has a particular interest in how clinical services are offered to ensure that all women have access to the benefits from genetic testing. Kristen Young has the BRCA12 gene mutation. Her whole family has been impacted by this discovery, and she wants to increase awareness in the community so other women and their families get a chance to choose. I'd like to begin the webinar now and hand you over to Associate Professor Alison Trainer to begin.
Good afternoon. I'm in the honoured position of doing the first web seminar from the New Victorian Cancer Comprehensive Centre here in Melbourne. And the subject I was going to discuss were the genetics of ovarian cancer and how, as a familial cancer centre, we can help families and individuals assess their risk and therefore be proactive in managing their risk in the future. So the first slide here just shows the ovaries and where they lie in association with the womb, which you can see here in the center, the two ovaries, and they're connected to the fallopian tubes. And whenever I discuss the ovarian cancers, in particular the high-grade serous ovarian cancers, you should think also that this includes any tumors that arise here in the fallopian tubes, as we know that these have a very similar origin to ovarian cancer. Now, there are different types of ovarian cancer that can occur. The majority that affect women over the age of around 30 are the cells here that line the epithelium of the ovary, and therefore they're called epithelial ovarian cancers. There are different types called germ cell tumors, which often occur at a younger age, and they have a different and in fact a much smaller genetic predisposition. Unfortunately, as we know, there is no screening at present for ovarian cancer, and if you are at an increased risk, the only way to significantly reduce that risk is to consider risk-reducing surgery. So that's removal of the ovarian tissue and the fallopian tissue, and this is usually done through keyhole surgery. But obviously it's important to try and assess the risk in order to determine whether that is or isn't the right approach to take. Once we've had a look at the actual anatomy, we can look at the pathology of the tumors. And this themselves is an important factor, as certain aspects, certain types of ovarian cancer are associated with different risks. As you can see from this graph, the large majority of ovarian cancers are these high-grade serous ovarian cancer, and we know that they can be associated with BRCA1 and BRCA2. But in addition, there are other types of cancers. The mucinous can also be associated with a different type of genetic disorder, and the high-grade endometrial, like the high-grade serous, can be associated with BRCA1 and BRCA2 mutations. It's important to know that borderline cancers, which are very early stage, non-malignant, are not associated. So it's very important when contacting a familial cancer centre or having a discussion with your treating specialist about ovarian cancer to be very clear in finding out what type of ovarian cancer it is that you have or that you know is in the family. Moving on to the next slide. The reason that we consider genetic testing is to try and identify women who may carry a fault in a gene, which may have implications not only to their own treatment, but also for assessing risks in other family members. And from all the information that has been gathered over the last around 15, 16 years since we discovered BRCA1 and 2, we know that around 14%, so 14 in 100 women who have a high-grade serous ovarian cancer will carry a fault in BRCA1 and BRCA2. Now, it used to be thought that if you did not have a significant family history, so if you didn't have multiple affected people, that the risk of carrying a fault was much lower. But in fact, some recent studies here in Australia have shown that of the women with ovarian cancer who carry a BRCA fault, around 50% of them do not have a family history. So in other words, we would now offer testing to women with a high-grade serous ovarian cancer, irrespective of whether anybody else in the family is affected. And obviously, without a family history, genetic testing is the only way to identify the fault and to work out the risk for other family members. As I said, there are other genes associated with an increased risk of ovarian cancer, and we know that the mismatch repair genes can also be found in women who develop particularly mucinous ovarian cancers. And we know that if we identify these faults, we know that other relatives and the woman herself is in an increased risk of bowel cancer and womb cancer. So that's another group of genetic syndromes which is important that we try and identify in order to assess risks. And this testing is done through the familial cancer centres. And these are found in all the states. Many states have more than one. And even if the state you're in has only one cancer centre, they do often clinics out in peripheries. So there should be one close to you. And what is a genetic test? Actually, it's a very simple blood test. The test is arranged through the familial cancer centres. It's not arranged through the GPs. It can more recently is becoming available through oncologists, and particularly in ovarian cancer. If your ovarian cancer has relapsed, we can offer testing through your treating specialist, and I'll come on to how to arrange that. And public funded testing is available for everybody who has a high risk ovarian cancer, and therefore that should be free of charge. If you have a history of the condition and therefore unfortunately we're unable to test the person who has the cancer, that's not publicly funded. And in Victoria we would charge for private testing at $800. That's really just to cover the cost of the test. Speaking to the specialists and coming to the clinic is all free. That's all publicly funded. And these prices are now dropping, so that should become more available in the future. So the questions that I'm often asked is this just research? And the answer is a categorically no. Genetic testing is now very much an important part of the clinical care of any woman who develops ovarian cancer or breast cancer with a history of ovarian cancer. And how will that help you if you already have the cancer? Well, we know that there are certain chemotherapy agents which are much more effective if we know that the cancer has arisen due to a BRCA mutation. And this group of agents is called the PARP inhibitors. These are now available. They should be on the PBS soon. They're available for women who've relapsed for ovarian cancer, and we hope that they'll become available for women at the primary diagnosis relatively soon. So by getting a test and by being found to carry a fault, it offers your treating clinician a different group of drugs to consider in how best to treat you. Will it also help your relatives? Yes. by identifying a fault in a woman who has ovarian cancer, we can then look for that same specific fault in any unaffected relatives. If they don't carry the fault, then they're not at an increased risk, and we can significantly reduce their anxiety. And if you do not carry a fault, you can't pass it on to your children. In the women who we do identify carry the fault, then we can help manage the risk and reduce the risk significantly. We know that we extend lives by identifying these faults in women who are well, so that because we can manage their risk before they develop any future cancer. At the moment, as I mentioned previously, unfortunately for ovarian cancer, screening is not possible. But there is risk-reducing surgery, and we tend to recommend that happens in your 40s. So it shouldn't in any way affect a woman's ability to have children, have a family. It does mean with this surgery that she will face a premature menopause, but we have links into menopause clinics to help decrease the symptoms associated with that. So the next question is, what should you do now? I'd recommend any woman listening to this who has ovarian cancer, speak to your specialist and ask to be referred to your family cancer clinic. We don't mind how old you are. Even if you have no family history, please ask for that referral. We are more than happy to speak to women, discuss their risk, discuss genetic testing, and if you want the test or not. It can obviously be quite confronting, especially when you're dealing with a diagnosis at the time, and you may decide that in fact this is something that you wish to consider again 2 or 3 months down the line, and that's fine. By coming to the familial cancer clinic doesn't mean that you have to have a test. It just means we can offer you more information so that you can decide whether that's something you wish to pursue. If sadly at the moment your cancer is currently relapsed, then we'd ask you to ask your specialist to phone the number there on the screen. That's 1-800-770-735. As currently we can offer testing in that setting quickly and easily with the support of the familial cancer clinic, but without actually having to come to the centre here. And that is to do with trying to access some of these chemotherapy agents that I mentioned previously. Lastly, if you have a family history, but unfortunately the close relative has died and therefore we can't test, it is worth coming to speak to us here at the Familial Cancer Clinic. We can't offer public testing at the moment, but we may in the future be able to test tissue samples, or we can offer you private testing. It's very important to realize that these mutations can come down through men as well as women. Men who carry BRCA1 or 2 mutations have a much lower cancer risk than women, and therefore we have many families where the mutation has been passed down through men, and through looking at the father's family history, we can often get some information in this regard. So don't think just because it's my father's sister who's got ovarian cancer that you shouldn't come and see us. We'd be keen to see anybody with a family history. The details of all the familial cancer clinics, how to contact them, are on the Ovarian Cancer Australian website. And if in doubt, please just give us a phone. We have genetic counsellors who are on the phone at all the time from 9 till 5 on Monday to Fridays, and they'd be more than happy to give you some information or to pass your details on to a clinic that's closer to where you live. And I hope that summarizes and answers in some of the details of questions that you had. But if you have any questions, I'm more than happy to answer them now.
Wonderful. Thank you very much. This is Anne-Marie from Ovarian Cancer Australia. I'd like to invite people who are registered for this webinar today, who are participating. If you have any questions, please take a moment to type them in. There's a chat box at the left bottom corner of your computer, and if you just type in your questions, then Alison will be able to respond to them. In the meanwhile, whilst we're waiting, oh, fantastic. got one question. Jeanette T asked, I have been offered $1,200 to send my tumour to Germany to see if I can go on a laparab. I am BRCA1 and 2 negative. Jeanette? Yep.
Hello, Jeanette. From my understanding from your question is that you've had testing on blood sample and they have not found a mutation. And we know that some women can have a mutation in the tumour, which is called somatic, so it's not picked up in the blood. There's probably about a 1 in 10, 1 in 20 chance of that. I think the question is you should be able to access such testing in Australia and discuss it with your treating oncologist. The oncologists that are currently running trials in Australia are Claire Scott at Melbourne Health and Linda Malishkin here at the Peter Mac.
Thanks for that, Alison. That's great. Jeanette responded that you got it right with what you had said about her situation. We've got a question here from Annie who's asking about clear cell type, and is that genetically inherited?
I would say that the clear cell types are a much smaller group of the ovarian cancers, and we don't have as much information about that group. So at the moment, we would count that as having a genetic predisposition, and we certainly would test you if your clear cell type was a high-grade ovarian cancer. So it's more to do with the fact that we don't have information, and therefore we assume that most high-grade ovarians are a risk, and testing would be your best option.
Jeanette T has just responded to say that she's living in Sydney, Alison. And could you just confirm that you said Claire Scott, and I think it was Linda Malishkin?
Yeah, Claire Scott and Linda Malishkin are here in Victoria. Professor Michael Freelander is at the Prince of Wales Hospital in Sydney. I would perhaps contact him and ask about recruitment to studies.
Thank you. And then there's a question from Virginia S. For the BRCA2 carriers, what age should women have their oophorectomy?
That's it's difficult to be too precise about this. The BRCA2 tends to be a slightly older onset than the BRCA1, and we normally recommend that women start considering having their ovaries removed in their early 40s, so between 40 and 45. We know that the risks can start earlier than that, but actually the risks are very low at that point. So it's a case of trying to weigh up the issues associated with early menopause with the cancer risks themselves, but in your early 40s.
Thank you, Alison. That's from one of our participants. Jeanette asked, is it free up in Sydney also?
From the tumour testing, I'm not sure. We, at the moment, looking at tumour testing, it's done either through a study, in which case it may be free, or if there's no study open and that you're having to source that because you're hoping to pay for the PARP inhibitor yourself, then you may have to pay for that.
Thanks, Alison. I've got another question from Sue H. Should sons of women with ovarian cancer be tested? I believe you spoke to that before.
Yes, I think, as I said, it can be passed down through to men, so that if the lady with the ovarian cancer does have a BRCA1 mutation, there's a 1 in 2 or a 50% chance that she can pass that on to her sons equally as to her daughters. The clinical significance in a man is less. He, with a BRCA2 in particular, is an increased risk of prostate cancer in his early 40s. Unfortunately, testing in unaffected individuals is not publicly funded, so there would be a cost associated with it. And the majority of men we see in this situations, it's because they are having children themselves and are concerned about any possible future risk to any daughters that they have.
Thank you. Virginia S. asks a follow-up question. Can we have hormone replacement therapy when menopause is caused by oophorectomy for BRCA2?
Yes, there's been a lot of controversy about this, and I think initially we were very conservative about hormone replacement therapy, but now it's becoming much more acceptable. There are different means of addressing different symptoms for menopause, but certainly if the first the first methods aren't successful, hormone replacement therapy at a low dose and only up to around the age of 50 doesn't seem to affect your risk, your breast cancer risk, which is really the concern with hormone replacement therapy. I would recommend that if that's something you were considering, that you contact one of the menopause clinics, and certainly here in Victoria we have one run by Professor Martha Hickey at the Royal Women's Hospital, and she would be a good person to contact and ask. It's not really the forum to discuss more personal symptoms that you may have, but there may be other issues or other forms of treatment you might wish to try first.
That's great, Alison. Thank you. Are there any further questions? Alison, there was a couple of questions sent through during the registration process. I wonder if I may bring that to your attention again, and just to ensure that we've covered it.
Yep. The questions that came through were mostly in regard to whether these mutations can be inherited from both mothers and fathers, and yes, they very much can. It's important to look into your father's family history as much as it is to your mother's. Another question asked, I have 6 sisters and a brother, and we are concerned about other siblings acquiring breast and ovarian cancer. My mother died of breast cancer. I think in that family history, I'm unsure whether the mother with breast cancer is the only affected individual, but certainly it'd be worth contacting a familial cancer clinic. We will take all the family history givers, particularly the age and the type of breast cancer. The familial aspects of breast cancer are somewhat more complex because it's more common than ovarian cancer, and therefore we assess the age at which it occurred, the type of breast cancer that it occurred, before we can come up with an assessment and decide whether genetic testing would be helpful. The next question is whether genetic testing is available to women whose mothers died of ovarian cancer. Unfortunately, at present, it's not publicly funded. We are trying to work technically to be able to try and test tumor tissue, and I think that would be a big step forward in the future, because many pathology departments hold on to ovarian and many cancer tumor tissues, and if we can access this and do testing on them, that would be the most effective way forward. If not, certainly here in Victoria, we would be offering publicly funded testing to anybody in that situation who wished to pursue it, and we would currently charge $800. I'm not sure at the moment whether all states are able to offer that. And the question 6 is a woman very much asking, she is BRCA1 and 2 wild type, and was wondering what options that she had for treatment. And again, I would recommend that you contact either Claire Scott at Melbourne Health, so that's Claire with an E, Scott at mh.org.au, or Linda Malishkin at the Peter Mac. And I'll make sure that those email addresses are on the Ovarian Cancer Australia website. And even if you're not in Victoria, they may be able to put you in contact with people having studies ongoing in other states.
That's lovely, thank you. Jeanette T has posted that Professor David Bottell has access to her tumour through a study, and can that be useful to see if something can help, even though she's a BRCA1 and 2 negative?
I think it would be worth contacting David and asking him that question directly.
That's great. Is there any further questions from participants? Jeanette gave you a big thank you.
All the best, Jeanette.
Lovely. Well, I think that I could thank Alison very much for that, and now I'd like to pass you over to Kristen Young. Kristen has, as I said, the BRCA2 gene mutation, her whole family's been impacted by this discovery, and she's very passionate about increasing awareness so that other women get the option that she did not indeed herself have. I'd like to pass you over to Kristen now.
Hi, I'm Kristen. I have recurrent ovarian cancer, and I also have the BRCA2 genetic fault. So I discovered I had ovarian cancer back in 2009, and the high-grade serous, and was treated in the normal way with surgery and chemotherapy, and that went along in a pretty straightforward way. The picture of my dad there, my dad had died of prostate cancer about 6 years before I was diagnosed. And I think that was enough, and a couple of other things that made my oncologist ask the question is there possibly a family history here? The other thing that I think influenced her to ask that question was the fact that at 47 at diagnosis, and that's relatively a young age to be diagnosed with advanced ovarian cancer of that type. So I think that was what was in her mind. So I was very keen to have the testing. And so I organised that pretty much as soon as possible that I could have it. I didn't go to a family cancer service, but I was referred to a geneticist who worked closely with the treatment team, not as an actual service, but he did the same thing basically. And I went there with a couple of family members and went through the provision of the family history and then the testing itself, so which was done at the public hospital. And in those days, the wait to get the test results back for the first person who's tested in the family, it took me 4 months to get the results. That was okay because I was still progressing through chemotherapy. I had plenty on my mind. So now I'll just talk a bit about the family. The picture is me with my chemo pearls. I normally have straight hair, as you can see, and that's my mother and my brother and my sister. As I said, my father had died of prostate cancer. His twin sister had also died young of a bilateral breast cancer, and I say young, under 60. And their mother also had some form of breast cancer, but not too sure what it was. But that's as big as the family was. That was a very, very small family. And of course, there's no ovarian cancer in that story. But true enough, when the testing came back, it did become, I was BRCA2, and suspected it had come from the father's line. As my mum, who's in that picture, is still living, and still is living to this day. Hi, Mum. We just to be sure, she, after counselling from the genetic advisor, agreed to have testing herself, just so that we could rule it out that it came from her side. If it came from her side, then there were issues about she has a much larger group of relatives on her side that might be affected. But knowing that it came from Dad's side, small family, only a small number of people affected. So that does make it a little bit easier to manage. It's a picture of me during my first chemo with the usual hair loss and all that sort of thing. But I've done my reading during my chemo, and I had heard that there are advantages in being BRCA2 positive, and one is that you tend to be more treatment responsive to normal chemotherapy agents. That's what I was told, like not necessarily a whole lot more, but a little bit more. And perhaps for that reason, they tended to have, people with BRCA2 tended to have slightly better survival curves. So that was the good side. But then there was the whole thing is, what do we do with the rest of the family? And this is where, cancer in one family member definitely affects the rest of the family. But when the genetic faults are involved, it affects the family in a whole new bunch of ways. The first thing is I don't have children. So that was one of the biggest issues, wasn't an issue for me, and that is, have I passed anything on to my children? No children, so it's not an issue. Then there was the question of whether my siblings wanted to be tested. Again, that's me on a road trip after my first chemo, getting back out there and trying to enjoy myself. So they had to decide what they wanted to do. So my brother and my sister both got tested, and I have their permission to say that they both tested positive as well. So we think we're a bit of a particularly lucky but unlucky family to have 3 out of 3 who all carry the BRCA2 mutation. So I'll just talk a bit more about my experience, and then I'll talk about the family, the effect on the family. It's a funny thing when you have this, because part of you has got relief because, oh, you know that, oh, maybe there's going to be more treatment options. But sometimes the sense is a little bit like, oh, am I somehow to blame, or do I feel responsible in some completely illogical way for causing health problems to the rest of my family? I know that's not true. Obviously, one hasn't done that. But it's funny how that goes into your mind, that you worry that somehow you're responsible. And I imagine that made it feel a lot worse for people who have their own children. So I had a long remission after my first treatment, and I did really well for about 4.5 years. And then in 2014, I had my first relapse and went back into treatment. So the very first thing I had been talking about it all along through my remission is, when you relapse, we're going to look at a PARP inhibitor trial. As you probably heard mentioned earlier in the presentation, PARP inhibitors are known to be particularly effective with the BRCA, and I was desperate to get on a PARP trial. I went to considerable lengths and effort to make sure I was able to meet the criteria. To give you an example, you have to have a certain hemoglobin level to be accepted onto the trial. So I was having trouble getting that. My hemoglobin was a bit low. So leading up to it, I was eating huge big red steaks and dehydrating myself so that the hemoglobin levels would come up in the blood, because I really wanted to get on that trial. So I did, and I've been on that trial now for the last 2 years. So this is all the upside of BRCA. And the downside at a personal level, because most of the downside is for the family, but the downside personally is the risk of breast cancer. For a lot of people, this creates a very high level of anxiety. They've already had to deal with ovarian cancer, with the very dramatic surgeries that go with that, and now they might also have to deal with breast cancer. So this generates a very wide range of different responses that people have to this. My response to this is just to participate in a high-risk monitoring program at my hospital, where I'm called in every 6 or 12 months, and there's a predetermined schedule of testing and examinations, including breast MRI. So as far as I'm concerned, they're looking after that. The other issue is about some people consider having a preventative mastectomy, but there's a whole formula that one needs to look into about whether that's worth it for a particular individual, and your age group is a factor as well. But that's a technical thing you might want to talk to your doctor about. There's me and Mum at a fundraising event for people with metastatic cancer. So it's a funny feeling being a gene mutation. You kind of feel special in a way, but you also feel like you're a marked woman. You've got this fault, and you know that, and you have the sort of, you know, is the axe waiting to fall. But the advantage is that if it does start to fall, you probably do better on treatment. Let me talk about the family a bit more, because it's when you're the one with the cancer, it's pretty obvious what you're going to have to do, all this stuff to try and, you know, save your own life. But the family members are faced with a different bunch of decisions. They're faced with decisions around preventative surgeries or preventative medications, which, you know, is an option, but they don't actually have any ill health yet. So they have to make decisions that will affect their health by these preventative actions without actually having cancer. So perhaps giving themselves early menopause, blah, blah, and that type of thing. And the privacy is one, I think, of the most difficult issues. People worry about if it gets out or becomes known that I have the gene fault, might I have trouble getting life insurance, for example, what's the implication for my family and their financial security? Is it something, if I know, if it gets out that one of my family members is BRCA, then everyone might think that I am too. So they might ask invasive questions or my privacy might be breached. So it's quite a lot of a challenge to work out if you're a BRCA carrier, should you even talk about it publicly, because other members of your family will be in the public eye as a result. So children, that's the difficult one. And it's things like the age of children in families where adoption is an issue or assisted fertility has been an issue, and where genetic lines are not clear, or any of those things have gone on, it makes it doubly tricky as well. If there's a child that has not been brought up in your family but may have your genetic material, how does that child get access to that information? So in terms of the message, of course, there's lots of myths, and I'm on my way, almost sort of finish what I'm going to say now. A lot of fear and a lot of myths, and I understand that there's something to be fearful about, but that the knowledge and support is much better there. If back when my dad had prostate cancer, they were able to identify that there was a family history, which was difficult given the family was small and genetic issues were not so evident back in those days, they might have tested us and I might not have had ovarian cancer. So, but, you know, you can't regret what you can't change, but yes, it would have been nice and I wouldn't have had to go through all of this. So there is an advantage in asking the question. But when you're asking the question about yourself, I found that it helped to ask every relevant family member how they felt about it before I took the next sort of action. So yes, it's not just the BRCA2 and 1, not just breast cancer, it's ovarian cancer. Small families, you know, you've got to watch out. The families are too small to get an obvious family history. Watch out for the father's line. Watch out for how you will feel if you get the test results back and they're ambiguous, which can often happen. And if you've decided that you want to know, once you know, you can't unknow it. So you can't take that knowledge away. So you have to really take that counselling from the Family Cancer Services to decide how it would help you if you did know. Would it change what you did to know? Do you really want to know for sure at the age of 20, for example, if you know that the best time to have the preventative surgery is when you're 40? You know, these are the things that are not straightforward and you can talk to the Family Cancer Service about. So that's my story in a nutshell, and that's what I feel as someone who's BRCA2 and likes to dress up in teal and go to things, as you can see. That's what I think.
Thanks very much, Kristen. Again, I'd just like to invite participants to ask any questions that you might have with Kristen. Kristen, already there's some comments rather than questions. Annette, I'm Kristen's mate, and I'm sorry to report that we missed a photo of the 12 apostles on that road trip. They were too busy talking. And what a legend you are, Kristen. You're a real fighter.
Yes, and that's my friend Annette's shoes I'm wearing. No, I think you've got to keep on the move, and I think trying to do as many normal things as possible, even when you're unwell, and try and live a normal life if you can, even though it's much reduced by your illness. Yeah.
Kristen of Jeanette T has just said, thanks, that was a fantastic presentation.
Thanks, Jeanette.
I wonder, I've got a question for you, Kristen. I'm just wondering how you found the counselling. You did the counselling yourself, and how you found that?
I did the which myself?
The counselling, the genetic counselling when you went to testing.
He was actually it wasn't a family cancer service, as I said, but it was a geneticist. He was a scientist that works closely at the hospital. So he's very, very knowledgeable. And, well, he just had the technical knowledge, but also what he was able to do is explain to other members of the family what their risks were, because that's something that I can't do, and it's not even my place to do it. And as I said, one of the hardest things about being BRCA positive and all of that is knowing that the other people around you might have it too and have their own issues. So if you have an expert such as the genetic counsellor who can reassure and explain to the family members, it takes the pressure off the individual. Because I said you get this completely irrational sense of responsibility that somehow you've caused their problems, which you haven't. So having an expert and someone who knows how to explain it takes a lot of that pressure off. And I would always just say to people, go to a family cancer service. And certainly a lot of the members of our extended family have done just that.
Thank you, fabulous. There's a couple other comments. Virginia S. Virginia is your sister. And she's just mentioned that because you've got the cancer, she's been able to avoid the cancer.
Mm. Yeah, so everything that the person with cancer does has an impact one way, or good or bad, on the family members when it comes to the genetic thing. So if you decide not to be tested, that has one type of impact. If you decide to be tested, that has another impact, which can be good in some ways and bad in others. My position all along is to do it all in consultation. And when families are in conflict or have separated by distance or some other reason, that would be a lot more challenging.
Indeed. Virginia goes on to say that one of her daughters was tested at the age of 22 because she wanted to decide whether to start her family, and she found that she was negative, which was really fortunate, and now she doesn't have to rush to have a family.
Mm. Yeah, so whereas you might say, oh, do we really want to test? Does a young person really want to test because, what if they found out they were, maybe they'll feel very, very anxious and want to have dramatic preventative surgery. At the same time, finding out allows a young woman like that to make that sort of decision. But this is why you need the family counselling by the people trained in genetic counselling to look at those fors and against, because it's absolutely not a black and white decision.
Thanks, Kristen. Do we have any further questions for Kristen? Is there anything further, Kristen, you would like to share?
No, if any questions come in as we're winding up, I'm happy to answer.
Alison, do we still have you online?
We do, yes. Hello.
Hello there. I was wondering if you could just pass on that message that you passed on to me about Linda.
Yes, I'd been contacting Linda Malishkin about possible studies for women who are BACR wild type. So that was in reference to Jeanette's question. She said there are some immunotherapies. There are some anti-PD-1, which is immunotherapy. You'll have there's been quite a lot of news about it in the press in regard to melanoma. And I believe there are some trials open. So I would advise anybody who needs a trial in particular, I think it was Jeanette who contacted, to contact Linda Malishkin, and she's at thepetermac.org. You may be in Sydney, but she would be able to let you know whether the trial is open in Sydney and who you should contact about that.
That's great. Thanks so much for following that up. Yes, go on.
I was going to say, I think I could see Jeanette typing.
So Jeanette's got as far as saying that she was at the North Shore Hospital and she was supposed to go on a trial.
Okay.
And we was wait for the lapse in the typing. Yes. Jeanette said she didn't actually get on the trial, but she was accepted.
But then the trial closed before you got recruited, was it? Well, I would contact Linda here and have a word with her about possible trials, and see what options you have. So that's Linda Malishkin here at the New Victorian Cancer Centre. So the telephone number will be different. I'd advise you to have a quick look on the website.
I can say something else about the trials, is that I feel, even though it was a close run thing, that I would actually get on that trial. I was down to trying to meet the eligibility criteria in the week prior to it being scheduled to close. I'm so glad and I'm so lucky that I'm on it. And I know I got on it because of the BRCA, but it's a weird thing, is that you feel, I suppose we're getting off genetics and onto trials, but when you're on a trial, you feel like, you're really lucky, and the other people who just have to wait and see, like most people do, you sort of feel a bit guilty to be that lucky. So, yeah, I don't know why. It sounds funny to say that I'm lucky that I've got a gene mutation that gives me cancer, but I really see it that way. And I was very, very pleased to have it. Not so pleased for the family, but now that I've actually got ovarian cancer myself, it's the way to have ovarian cancer with BRCA.
Can I just give Jeanette the number? So the number for the new Peter McCallum is 03, that's Victoria, 8559 5000. So that's 03 8559 5000. Yes, you've spelt her name. It's an I instead of an E at the beginning, and the email address is at petermac, petermac.org. So her name is spelled Mile, MILESHKEN. That's right. You have the telephone number. Correct.
Excellent. Wonderful.
Thank you.
Thank you. And one final call out for questions before we wind up the webinar. Could I ask if there's anything further that Alison or Kristen would like to share before we close it up?
Well, I just noticed that my sister Virginia has commented that trials give you hope as well as treatment.
Yeah.
And yeah, the feeling that I have that I'm a special BRCA person, and that something always seems to be coming up for us BRCA people, is that oh, this is going to work better, or we've got a new thing being developed for you guys. And jokingly, I always say it always pays to be more interesting to your doctors. And, though I don't mean to say that doctors don't give everybody equal care, because of course they do, but when it comes to new research and new ideas, genetics are currently where it's all at, and that just puts me in a really good position to benefit from new ideas, and hopefully that will trickle out to the family as well.
Thank you. And sorry I missed that, Virginia. You're right. Trials do give hope, and I think hope is what's really important for this cohort. Thank you very much. So this brings us to the end of the webinar. If we don't have any further questions, I'd really like to thank Associate Professor Alison Traynor and Kristen Young for being our guest presenters. We really do value and appreciate the information and the time that you've invested in us today. So for our participants, the webinar will be recorded and it will be available on our website early next week, within a week. Thank you everybody who's attended today's webinar. Your feedback is very important to how we develop and deliver programs. If we please take a moment to fill in our online survey, you'll be directed to that as soon as I finish talking. And one final thing I'd like to say is that Ovarian Cancer Australia has launched our new and improved online community forum. OCA Connect is a place where you can join with other women with ovarian cancer to seek support, advice and information. You can find information on that on our website. Okay, once again, thank you to our presenters and we'll see you at the next webinar.
Thank you. Pleasure.
Thank you.
Thank you.
Thanks.